Boston. Interestingly, I don't actually work in Boston. Well, I don't cover Boston. I cover further north. So it's sort of Skegness all the way around to Market Raisin, the old East CCG without Boston. So that's me. I've been in post, gosh, I think it's 19 years now. And the reason I'm giving this talk is because I do have an interest in autism. So though I'm an ID psychiatrist, we do see a lot of autism in ID. And we also have an autism diagnostic service. So I'm also involved in that too. So I'm hoping to speak for about an hour, but please do interrupt with questions. And I suspect the most useful bit is going to be the questions at the end, but let's see how we get on. So I always hate it when they do this, but I've done it. The sort of things I'm going to look at. The main thing, I want you hopefully to understand the deficits a person with autism experiences. So if you forget anything else, that's what I'm hoping you remember. Then we got the historical perspective, which is very interesting. Well, certainly I find it very interesting. The reasonable adjustments I think you'll find very useful. It might help you understand better how to talk to people with autism. And then the last bit is a bit dry. It's just the epidemiology. And I'm more than happy if we don't get onto the epidemiology, but I'm more than happy to share the slides. In fact, Runa's already got them, so you'll be able to get them after the presentation anyway. So what I'm going to do then, I'm going to start with a diagnostic history. And I should say that this comes from a book by Uta Frith called Autism Expanding the Enigma. So if you do want to look it up, Uta Frith, UTA Frith. So she describes this boy called Victor. Sorry about the awful sound effects. Oh, sorry, let's go back. She talks about this boy who was in Aveyron in France called Victor. And he's a real person. This isn't fictional. And he was basically found in the woods. You know, he'd lived several years in the woods, completely wild. And he had no speech, didn't respond to questions or noise, but interestingly, didn't even seem to have the quite human characteristics of things like friendship, pity, embarrassment. And they described him as having this unbounded egoism. So the question is, was he like this simply because he'd had no human contact, or was he like this because he was in some way different? And I would argue that things like friendship, pity, embarrassment, they're pretty human characteristics. So perhaps he was fundamentally different.
In a village outside Lincoln, and transport links are terrible.
Can people just mute, please? Thank you. And also the fact he had no response to questions or noise suggests something was different. Because you think if you're going to live in the woods for several years, surely you're going to respond to noise because you're going to be hiding from wolves and, you know, other predators. So it suggests he was fundamentally different. And a local physician called Itar tried to educate him, but after 5 years resigned, stated that his education would probably remain incomplete. And Victor was never able to live independently and died in his 40s. So there was something different about Victor. So was he autistic? We will never know, but he certainly had some significant features of autism, which hopefully you'll pick up as we go along. So that's the first example. The second example, I think this is a real character, was Brother Juniper. So he was a monk in a monastery, and one of his monk brothers was sick. So what he did is he cut off a pig's trotter and cooked it and presented it to his brother, you know, to help him. The trouble is, though, the pig was still alive, and Brother Juniper had no concept of the suffering he'd caused the pig. So again, you would have thought it's pretty obvious that you're going to cause suffering to the pig, and yet Brother Juniper had no concept of this. So you might argue he was a psychopath, because they say that psychopaths have no empathy. Or perhaps he was autistic too, in that he didn't seem to understand the point of view of other beings, albeit a pig. The next one is fictional, Sherlock Holmes. But if you remember about Sherlock Holmes, he's quite absent-minded when thinking about people, but he's incredibly observant. He's very, very clever, not clever, but very, very observant. He really absorbs trivia. He's very single-minded. I saw an episode of Sherlock, the TV series, and I remember, I think it's Dominic Cumberbatch, immediately focusing on the rings on somebody's finger and focusing on the clothes they were wearing, whereas you and I would probably be looking at the face and assessing the eye contact and assessing the emotions of the person. So yeah, Sherlock Holmes, though fictional, seems to have been fundamentally different. Whereas Watson, much more, dare I say, human, much warmer feelings and also associated prejudices, whereas Sherlock Holmes much more single-minded and perhaps not having those prejudices. And this is an interesting thing because people with autism often say that actually we, who we can call neurotypical, the neurotypicals actually have the problems because we have these prejudices, we lie, we cheat, and these are things people with autism probably don't do. So I told you I was going to talk about the diagnostic history. What happened was, on both sides of the Atlantic, completely independently, two different clinicians began to talk about what we come to know as autism. So in Baltimore in the US, you had Kanner. Note the year 1943. I wish I didn't have these silly camera things. So he coins the term early infantile autism. Autism hadn't really been used much before that. I think Bloiler used the term autism, but it's in a different concept. But auto, I think, means self in Greek. I hope that's correct. So you can see it's something about the self. And Kanner described autistic aloneness. So the idea being that these individuals just had no human relationships whatsoever, completely alone. And also they had this obsessive insistence on sameness. So you could say quite obsessional. Also socially aloof and indifferent. So they didn't seem to have the normal social interactions. They didn't seem to be sort of interested in the normal social interactions. And then some of them had no speech whatsoever. Some of them would repeat speech, echolalic, or some of them had quite idiosyncratic speech, but all of them seemed to have abnormality of speech. And perhaps one of the core features was they were intensely resistant to change, and any sort of change would have made them highly anxious. And then also he noted that they seemed to have these isolated skills in visuospatial or rote memory, but it tended to be very sort of concrete skills, very black and white skills. So it wouldn't have been skills in art. It might have been skills in mathematics or, like it said, in memory. What's important about Kanner's individuals is that they had sort of, dare I say, severe autism. So really, really obvious autistic symptoms. They most likely had learning disabilities too. And we do now use the term Kanner's autism to mean very severe autism, typically low functioning as well. So that's Kanner in Baltimore, 1943. Then you got Asperger, as you might have guessed, the year later in Vienna, but no contact with Asperger whatsoever. He again used the term autism, well, autistic, and he described this autistic psychopathy. And it was a much wider spectrum than Kanner's individuals. And as you now, well, this is actually out of date. It used to be that Asperger's syndrome was reserved for people of normal intelligence who were perhaps highly verbal. And the poor motor coordination, I'm never sure about. I always think that that's a bit of a red herring. But anyway, Asperger's is basically no more. It used to just mean people of normal intelligence with autism. We now just say people have autism. And we talk about the autism spectrum. But yes, anyone with autism, sorry, so Asperger's were just normal intelligence on the autistic spectrum. And what Asperger did find that patients showed increased adaptation and compensation with age. I think that's probably because they were higher intelligence than Kanner's group. So they were able to learn some of the rules, and I might come back to the rules later. They were able to learn some of the social rules, but they wouldn't intuitively learn them like most other individuals would. Any questions so far, or are we okay?
We're okay at the moment, Peter.
Okay,
Thanks.
so do put your hands up or let Runa know if you have got any questions. Hang on a minute. There we go. So the diagnostic criteria now are from Lorna Wing. And Lorna died a few years ago. It was quite interesting. I actually saw her obituary in the paper. It was just there. I only get a paper once a week, so I was amazed. But yeah, she died a few years ago. But she was basically the doyenne of the modern concept of autism. She was the first person to talk about the autism spectrum, which I've alluded to. And she talked about this triad of impairments, which are contained, I think it's at the bottom. Yeah, they're in ICD-10 and DSM-4. Again, this is now out of date because it's now DSM-5 and ICD-11 is virtually with us. Interestingly, I haven't looked at DSM-5, so that's some homework for me, but I suspect that Wing's triad will still be there. So the first one of the triad is this qualitative impairment in reciprocal social interaction. So that means that the people, they just struggle with meeting other humans at all levels. And I'll come back to talk about this. They then got this qualitative impairment in both verbal and non-verbal communication. So normally, well, I used to do this presentation face to face, so I'd be able to look out at your faces and I'd very quickly be able to get an idea about your mental states, because you might be smiling, some of you might be yawning, hopefully you look alert, some of you might be sat relaxed in your chairs, others might be sat upright, and I'd very quickly get cues about how you're feeling. Somebody with autism wouldn't get any of that. They would just see a sea of faces, and it would be like, well, to use Oliver Sacks' analogy, it's like being an anthropologist on Mars. So it's like having a group of aliens with you that you just don't really understand. And then the third of Wing's triad is this markedly restricted repertoire of activities and interests. And this really is heading towards those islets of ability that I alluded to earlier, where people can have these particular areas of very high ability and strong interest. What I haven't talked about is an imaginative play. And I have to say, I'm never quite sure why Lorna Wing put imaginative play under number 2. Because I always think that's separate. But anyway, that's the way she's worded it. So the idea being that individuals can't, perhaps they have a limited imagination. And so imaginative play would be particularly difficult. And of course, this is particularly true in children. And when we do the diagnostic interviews for any individuals, we always need to get the developmental history, and whether or not the individual could engage in imaginative play is very crucial in the diagnosis. There may be 3 types. I think this is just about level of functioning. So the first ones, I think these are the lowest functioning. So these will be the one with probably the severe learning disabilities. So they will approach others for basic needs, but that's it. Otherwise, they tend to be very aloof on their own. Communication is very limited. Again, I think that's because they've just got learning disabilities, more severe learning disabilities. They may be mute. Joint referencing is basically, it's where if you think normal children, they'll say, "Mummy," I'm pointing, "Mummy, mummy, look at the plane." So they point at the plane, they look at you, they look at the plane, and they point at the plane. And that's something we all do without even thinking about it. And the idea being that this aloof category or this aloof group would not do that. And again, in the diagnostics interviews I do, that's one of the questions. Poor eye contact is another feature of this perhaps subgroup, but always be a bit careful with eye contact, because people often say he can't have autism because he's got good eye contact. That's frankly rubbish. I've known people with autism who make very good eye contact, and it could be that they've learnt to look into people's eyes, but also some people cheat. What they do, rather than looking in your eyes, they might look at your nose, they might look at your forehead, and again they've learnt a way round sort of avoiding eye contact. So yeah, be careful with eye contact. And then this group perhaps have lack of facial expression and gesture. That's fairly typical of autism, but again, probably because this group have got the most severe learning disability, and they may be unable to copy. So that's the first group. Like I said, I think they're just the lowest functioning. Then you've got the passive group, and they will accept the advances of others without protest. But if you went to hug them, they probably just stand there very stiffly. They wouldn't particularly enjoy human contact. Because, like I think they're higher functioning, they may have better speech than the aloof group, but the speech might be repetitive or echolalic. If they're are they best behaved? I'm not sure. And they may manage mainstream school. I would argue probably they're likely to have some degree of learning disability, so they might manage mainstream school until secondary level, and then I think most likely they would still be going to special schools for secondary education. And then the last group is the active but odd. These are probably the highest functioning, and these have quite peculiar approaches to others. I always remember a chap at university who would come and talk at you. He wouldn't talk with you, he would talk at you. And he was doing a PhD in three-dimensional shapes. And when I say three-dimensional shapes, this is maths. These shapes had sort of, I don't know, 50 sides. So extremely complex what he was doing. And this was his eyelid of ability. So that, as it says there, they can talk at you rather than talking with you. Conversation isn't reciprocal. The bit about motor coordination, I've never been convinced about. Like I said earlier with Asperger's, they stated that people with Asperger's may have problems with motor coordination. I'm not sure about that. And the modern terminology now is that it's all just autism. And I suspect some people have problems with motor coordination and some people don't. So again, I think that's a bit of a red herring. But this group may get into legal problems, probably because they're highest functioning. I had a woman with autism who went to the local shop, and in the shop there was like a security barrier. So you had to walk basically through the security barrier into the shop. Then you walked round the shop to get to the till. All she did was she went straight to the till. So in doing so, she'd walked through the barrier, and the shopkeeper accused her of shoplifting. She wasn't shoplifting. She was just taking the quickest way to the till. And the shopkeeper didn't understand that. So she could very easily have got into legal problems. Luckily, I think she had a support worker with her who was able to explain to the shopkeeper that actually she was a very law-abiding citizen and she was just taking the shortest route to the till. But again, it's this idea that she didn't understand the usual social norms. She didn't understand that if she did that, it would look as if she was trying to shoplift. And yeah, some may fit Asperger's. So this is where hopefully the talk gets really interesting, and this is sort of the nub of the talk, trying to work out what it is actually that's the central problem for people with autism. So you've got Hobson in 1981, who suggested it's this impairment of effective response. So the idea being that we ought to have this effective response with others is how we develop relationships, how we become emotionally involved with others. And if we don't get these social relationships in infancy, then we don't develop cognitive structures secondary to that. Hence, we can end up with problems with autism. I don't agree with this theory, but it is a theory. So that's Hobson's theory. Second one was Tager-Flusberg in 93. And they talked about this failure in development of language, communication and social skills. So it's really a failure of communication. Obviously, communication exists for info exchange. And they argued that development of language is inextricably linked to understanding of others' minds. And I'll come back to theory of mind in a minute. So that was Tager-Flusberg's idea. However, I think by far the best theory, it is only a theory, was by Baron Cohen, and it's a theory of mind. So the theory of mind basically states that we all have individual mental states and we all see the world slightly differently, but we also understand that other people see the world differently, that other people have different theories of mind. As I was saying earlier, if I were in a room with you, I'd be watching you all and I'd be able to get an idea about your inner mental states just by the expressions on your faces, by how you were sitting. And I would know that some of you would be thinking about other things. You know, you might be thinking about picking up the kids from school. You might be thinking about what you're going to do tomorrow. You might be thinking about a particularly difficult patient that you've seen at work today. But I would have an understanding that you all had different theories of mind, different mental states. And this is the idea that actually somebody with autism doesn't quite understand that. So they don't develop the normal understanding that people have minds and different mental states. This theory can be criticised. And I can tell you that I've known people with autism who do understand that other people have different mental states. They do understand that people see the world differently, but they can't decipher any of it. So we're back to the verbal and the non-verbal communication. We're back to this anthropologist on Mars. They look at the sea of faces and they just can't work out other people. So they know that there's things going on in other people's heads. They just have no idea what it is. So yeah, Baron Cohen's is probably the best theory. Perhaps one way of illustrating that was what you can do. It's called the Sally-Ann experiment. In fact, I will say this and then I'll ask for the correct answer. So you've got the Sally-Ann test. So basically, I should have nice pictures now, shouldn't I? Sally had a picnic basket with her lunch in. She comes into the classroom. She puts the picnic basket on the table and then she goes out to play. So while Sally's outside, Anne comes in and Anne sees the picnic basket and thinks, oh, so Anne eats the lunch, puts the picnic basket back, and then she goes out to play. So the question is, when Sally gets back, where does she think her lunch is? I'm not going to ask because it's obvious. She thinks her lunch is in the basket because she doesn't understand. Sorry, yes, she thinks her lunch is in the basket. But what you do, you ask the person that you're testing where they think Sally thinks the lunch is. Hope that makes sense. And somebody with autism would say, oh, Anne's eaten it, not understanding that Sally has a different point of view, a different mental state, and so Sally's not aware that Anne has eaten her lunch. Any questions on that? Because that's sort of the nub of the talk, and I want you to get that bit. Did that seem to make sense,
No.
Runa?
Yeah, it did. No questions, Peter.
Okay, so that made sense. So you ask the person with autism, where does Sally think the lunch is? And they will say it's in the basket. No, sorry, they'll say Anne's eaten it, not realizing that Sally doesn't know that Anne's eaten it. Okay. Another way you can test this is, say you have a chest of drawers and you hide a sweet behind the chest of drawers, and you show the person with autism that you've hidden a sweet behind the chest of drawers. You then invite somebody else into the room, say you invite John into the room, and you ask the person with autism, what does John think is behind the cupboard? And the person with autism would say a sweet, whereas other people would say he doesn't know because he can't see the sweet. So again, the person with autism doesn't understand that different people have different mental states, different points of view. So I'm more than happy to talk about that later if people want to. And then these are just other theories. They all have their merits. One is that there's problems with imaginative play, which we've already talked about. But this theory is that you can't use meta representations. So if you have a toy train as a child, that is a representation. So it looks like a train, it might sound like a train, it might work like a train. So it's a representation. And the theory goes that people with autism won't have a problem with that because they'll see the train, they'll think, oh yeah, that's a scale model of a train. Doesn't even have to be a scale model, but it looks like a train. However, if you then got a pen, again, I wish I was face to face with you now. If you got a pen and you place it vertically on the table and what you do, you go, and you're lifting the pencil off the table and you say, look at my rocket. That is a meta representation because it looks nothing like a rocket at all. But because I'm raising it off the table and making a rocket noise, a child would think, oh yeah, that's a rocket. Whereas the theory goes, somebody with autism would think, that's a pencil. Why are you making that silly noise? So the theory is people can't use these meta representations. So they can recognize a scale model or a model of a rocket or a train, but they can't recognize when something else is used that looks nothing like what it represents. Another one is abnormality of arousal. And I have to say, I don't know much about this, but I can tell you that my theory, which hasn't really been disputed, is that almost everyone with autism has anxiety, high levels of anxiety. There's also pretty good evidence that people have different levels of arousal, particularly sensory type issues. You probably know people with autism can have particular sensory problems, and I'll be coming back to this later. But in Utta's fifth book, she talks about an individual who basically was stood in a kitchen. This was an individual with autism, and the chef dropped a pile of plates. So the plates land on the floor, the hard floor, all smash, make a horrendous noise. The person with autism wasn't bothered whatsoever. But then somebody turned on the Hoover next door, and then suddenly the person with autism was really distressed. So it's suggesting that there's something about the sensory thresholds. It might be the frequency of the Hoover, who knows, but there's a difference in arousal and this difference in sensory thresholds. And another theory is connectedness. We all make connections all the time. My theory is that we actually make connections to lower our own arousal. If you think about your work, I'm sure you all have routine. You probably do generally the same thing on a Monday and then the same thing on a Tuesday, or at least similar things. So you have a routine in your head. I always remember when I was a junior doctor, when you start a new job, you haven't got a clue about the routine, but within a month or so, you've got your head around the routine, you've made those connections, and your arousal comes down. And the idea being somebody with autism can't make these connections. Uta Frith talks about a study that was performed to look at this further. What they got was they got 3 groups of children, similar age. So the first group were just normal children. The second were children with learning disabilities. And the third group were children with learning disabilities and autism. So first group normal children, second group LD, third group LD and autism. And what they did was they got the children to remember a sequence of words. So the first sequence of words were, I've got to count them now. Tommy and Bill went to see the clown. So Tommy and Bill went to see the clown. And what they did is they tested immediate recall. And this is where I wish I was face to face, but never mind. The group of normal intelligence could generally remember all 8 words. The children with learning disability remembered a few less, so perhaps 5. But the children with autism remembered probably 2. So that was the first test. Then the second test, they were again asked to remember 8 words. And the second 8 words were something like tree, table, sunshine, carpet, road, picture, wallpaper, light. So what they found was the children with normal intelligence perhaps remembered 4 or 5. The children with learning disability remembered a few less, but the children with autism remembered 2. So it made no difference either way for the children with autism. And what's interesting, it was the last 2 words. So the children didn't hear the sentence. See, I can't remember it. Was it something like Jack and Bill went to see the clown? I think that was it. The children with autism didn't recognize that as a sentence. They just heard words. So they remembered the last 2 words. Whereas the children of normal intelligence recognized the sentence, put it all together, and could suddenly remember it. So that's all about connectedness. I could go on and on about that, but we'll move on because I'm sure you want to hear more things. So I told you a bit about the sensory challenges people with autism face. This is a slide I've shamelessly borrowed from somebody else, but the principles are well known to me. So you can have either too much sensory input or not enough sensory input. So you can see here, if you've got too much auditory input, then you can't turn out background noise. We have one of our trying to think, one of the people we work very closely with has autism, and I remember meeting her at our dining room, not dining room, in our kitchen, and she said to me, she said, "Can't you turn that fridge off?" I said, "What do you mean?" She said, "Yeah, that fridge is really annoying." And then I noticed that the fridge was humming away in the background. So she couldn't tune that out. Whereas for me, I hadn't even noticed it. And then the opposite, if you're too low arousal for auditory, then you may enjoy loud places. It's similar to, I was thinking it's a bit like extroverts and introverts. You might not know, but introverts are actually over aroused. So they're trying to avoid arousal, whereas extroverts are under aroused. That's why they're always seeking attention. They always want to talk to you. So it's a bit like that. And other examples, smells. So yes, they might want to avoid perfumes. Same with textures, diet. I had a young lad with autism who would only eat Walker's crisps. But what's fascinating was that actually Walker's then changed the barcode, and unbelievably, this patient wouldn't then eat the crisps because the barcode had changed. But yes, it was something about the flavour and the texture that he wanted. We did slowly manage to introduce him to other foods, but very tricky. And touch is another one. I've known individuals who just can't tolerate clothes on their skin, and it perhaps less severe would be that they can only tolerate natural fibres, so they couldn't tolerate polyester, anything like that. And then motion sickness is a very interesting one, not one you typically think about. And yeah, you've got the opposite there. And you probably know people who rock or swing or spin. That's probably because they're under aroused and they're looking for the proprioceptive feedback. Interesting one about wanting to be held tightly. Certainly, generally people with autism do not seek physical affection, but if you hold them tightly, they can find that paradoxically relaxing. And then just an extension of that really is the stimming or the self-stimulation. And people can use repetitive movement, sounds, words, or moving objects. And it's probably to manage their own sensory over or under stimulation. And the examples there: hand flapping, clapping, rocking. I don't know if you remember a few years ago, there was that craze about the little spinning things. I can't even remember what they were called, but they were fantastic for people with autism. And it's something about the spinning. And one of the questions I have to ask on my autism diagnostic interview is whether people will flick their fingers in front of their eyes or whether they'll spin the wheels on a toy car rather than playing with a complete car. And that's another example of this stimming. I'm just looking at time. No, we're doing all right for time. So hopefully this bit will be particularly useful to you. How can you help? So environmental changes can make a huge difference. So look at the environment, see what could be causing problems. Of course, it's difficult because you might have to have some understanding of the person with autism, but lighting can be particularly distressing, fluorescent lighting in particular, particularly if it's buzzing as well. That can be very, very difficult. There might be smells there. So think of all the senses and think of what could be agitating the person with autism. And yes, there might be positive sensory experiences. So if somebody has the hypo arousal, they might enjoy smells. They might enjoy more visual input. But also be prepared. So yes, perhaps warn the person you've got to see and check that it's okay with them. So perhaps before you're seeing them in your surgery, perhaps ask, are you okay with the fluorescent lights? Are you okay with the fridge in the background? So yeah. Sorry, I've just moved things around so my computer's not happy. There we go. Another thing is be very, very careful in your speech. As you probably know, people with autism will interpret everything completely literally. So as it says there, say what you mean and mean what you say. So this one, if you're saying to somebody, oh, I bent over backwards, you and I recognize that as a metaphor, where somebody with autism, as shown there, they're thinking somebody's actually bent over backwards. So this is the very literal interpretation of speech I was talking about. Second one would be, I can't remember what this one says. That's right, you have to pull your weight. So somebody with autism might be thinking, what, I've got to pull 50 kilograms along with me. So it's this very literal interpretation of speech. Another example I heard was that somebody with autism saw a sign that said, keep off the grass, and they never walked on grass again. So until they were told, I don't know, years later, they just wouldn't walk on grass. Yes, they tend to interpret language very, very literally. So say what you mean what you say, try and avoid metaphors, avoid similes, and try and use very concrete language. And don't imply things, because the person with autism won't get it. You've got to literally say what you mean. So what have we got here? Yeah, so be clear. Sarcasm, irony, none of this somebody with autism is going to get. Yes, generally it's a case of giving somebody with autism limited choice. I don't understand why this is, but generally they do struggle with too much choice, and I suspect that's because it raises their anxiety levels, and then they're not able to think clearly. We've talked about eye gaze, and remember that if they're not looking at you, it doesn't mean that they're not listening. And what I actually do when I'm talking to people with autism, I actually deliberately look away from them, because I'm thinking, you know, perhaps they're finding eye contact quite anxiety provoking, quite aggressive, really. So I often talk to them whilst not looking at them, because that's a tip worth thinking about. And again, be aware of the environment that we've talked about. Oh, we're nearly at the end now. This is let's go back. Any questions on that? Because there's a huge amount I've just covered there.
I think there's been some really good top tips, but no questions.
Well, we can always come back to these.
Thanks.
So that we're now moving into the dry bit of the presentation. Epidemiology. I'm probably going to finish before the hour, which might be a good thing. But it's definitely thought to be a neurodevelopmental disorder, and it's thought to be some sort of organic brain disorder. I think it's a problem with the wiring of the brain. So I think it's at the microscopic level, and our scanners just aren't good enough yet to spot it. But I think with time, we may discover what the issue is. But as Mason Brothers talked about, it must be subtle, yes, and it must act in combination with and at the time of conception or very early in neural tube or fetal brain development. The other thing with autism, which I haven't talked about, it is a syndrome. It is not a thing. It is not an illness. You know, it's not a specific disease. I hate the word disease. It's not a specific disorder. It's just a constellation of symptoms that we lump together and then call autism. So yes, it's a syndrome. Whether we'll ever decide that it's lots of different disorders, I don't know. But at the moment, it's this constellation of symptoms that we then call autism. Prevalence. These figures are completely out of date, but I thought I would show them so you've got an idea how autism have moved forward. So it used to be stated, this was when I trained, so this was, oh gosh, I was talking to Runa earlier, this was probably 25 years ago, and we were told 2 to 20 per 10,000, so that's about, the maximum was 2 per 1,000, or 1 in 500. Now it's thought to be about 1%, so 1 in 100. So even by the most the biggest estimates of 25 years ago, the prevalence has gone up 5-fold. I've got to be careful saying that, because we don't actually know what's happened. It may be that we're better at picking it up. I think that's definitely the case. I think we used to just talk about Kanner's autism, which was the severe autism. Then Lorna Wing came along and actually said it's a spectrum. And now when I do diagnostic work for people with autism, when people first walk in the room, I often think, oh, they're not autistic. But actually, when you probe deeper, when you spend a few hours with the individual and you ask lots of questions, actually you realise that they do have autism. But yeah, thought to be around 1% now. The male to female ratio, again, this is probably incorrect. Used to be thought 3 to 1. Excuse me. But we now know that girls and women are much better at what we call masking symptoms than boys and men. So I've seen women recently who stated that throughout school they knew they were different, but they learnt how to fit in. They would associate with other girls, and they would learn the things to say so that they try to fit in. But actually, it was really, really difficult for them, and they probably got home every night feeling utterly exhausted because they had to maintain this act throughout the day. So yeah, now we think that there's many more females with autism than we thought. I suspect there's still more males than females, but it's probably 2 to 1, if not nearer 1 to 1. But I still think there's probably more males. 70% have ID. Again, I don't know if that's correct or not, because we now know that more people with autism are being picked up. So these are slightly historical figures. So it might be that perhaps that's less correct than it was. But we definitely talk about the autism spectrum now. So any level of intelligence can be associated with autism. But there is increased rates of epilepsy. And I think this is because definitely epilepsy is associated with brain damage. And I would argue that autism is probably some sort of brain damage at the microscopic level. Hence, because they're both brain damage, excuse me, hence you get the increased rates of epilepsy. That's my theory, but I suspect that's true. And then just a bit on genetics. It does run in families. Occurs in around 3% of siblings. See that, again, I suspect this is out of date, where it says a further 3% have a broader diagnosis. I suspect that actually means that 6% of siblings have autism. But again, that could be even higher now. Estimated 15% had a developmental disorder. I never quite understand twin studies, so I'm hoping you're better at them than I am. But my understanding is this does show that there's a significant genetic component. The bit about parents is an interesting one. If you go back several decades, they used to talk about refrigerator parents. This was when Freud and psychodynamics was all the rage. And the theory was that refrigerator parents led to having children with autism. So parents who didn't give their children affection, who didn't have the sort of human warmth that you'd normally give to your children. The theory was that that led to autism. That's been completely disproved. However, autism does run in families. And so I often see people with autism, and then I ask about the parents, and actually they often say, well, yeah, my mum or dad's very similar. So when it says the parents have personality difficulties, it may also be that the parents actually have autism too. Fragile X definitely associated. Again, I suspect those figures are now higher. But yeah, Fragile X is a known association. And I never know with this whether Fragile X causes autism or whether it's an association. So I can't answer that one, but it's definitely a recognised association. And then a bit on neurobiology. Post-mortem studies are inconclusive, but CT MRI do find these subtle differences But again, we don't really know what these mean. And I'm sure if you scanned one individual, you wouldn't be able to spot these differences. It's only when you scan a population of people with autism versus a population of neurotypicals that then you can see that on average there are differences. But on single scans, you're not going to see it. And it may be that there are differences in neurochemistry. I'm just trying to think. It says 5-HT is elevated. That's interesting because I do sometimes give people with autism SSRIs, which would raise the 5-HT even higher. But SSRIs can be helpful. And then it could be dopamine, could be opioids. We don't know. So yes, it's a complex disorder. Oh, have I just unshared? No. Hang on a minute. I've clicked the.
We can still see it.
Can you? I've clicked the wrong thing. Hang on a minute. Has the slide just changed? Here we are. I'm back. Sorry. Oh yeah, and this is the final slide, just to give you an idea of the situation in Lincolnshire. Like I said, it's about 1%. So I don't know what the current population is. I think it might be nearer 800,000 now. But it's estimated something like 7,500 individuals in Lincolnshire have autism. And nearly 4,000 are registered with a GP as being on the spectrum. That surprises me, actually. We can get into those discussions because I think there are a huge number who are still undiagnosed. And okay, 4,000 is a lot less than 7,500. But I'm surprised 4,000 are registered. And you can see there that the figures, according to the Lincolnshire Research Observatory in 2015, show a clear male preponderance. But again, I would question those figures because of the female masking. And the children to adults, I don't know quite what that means because it is a neurodevelopmental disorder. You can diagnose it by the age of 3. So I think that's more about the rates of diagnosis, whether that means more children are being diagnosed, whether that means that the children haven't yet grown up into adulthood, I'm not sure. And I think that is the end of the presentation. So let me come back to you all and have I unshared? So I'm being blinded by the sunlight, but it should be all right. So open to questions. So questions, ideas, please feel free to ask me anything on autism.
Thanks, Peter. We've got one question that Angela's put in the chat to ask. What questionnaire do you recommend to screen for autism in primary care?
Oh, that's an interesting one. We use AQ10 or AQ50. I don't even know what AQ means. I suspect it's autism questionnaire. The trouble is I don't know where you get it from. But yeah, we use AQ10 or AQ50 and it's very, very simple. So if you can get hold of that, I would recommend that. And that might then give you an idea whether or not the person is likely to be autistic. And then you might consider referring on. What's interesting, though, is that generally the people who are referred to us do have autism. So I think as GPs, you are pretty good at screening out the people who aren't autistic. But then I suppose the challenge is perhaps you're not referring to people who it's harder to diagnose. I don't know. So I don't know that one. But yeah, I think keep doing what you're doing because you're doing well. I'm just going to shut my curtain. Hang on a minute.
Okay. Peter, do you think then that there might be people that we are missing that would benefit from your services? Is there any kind of person, adult or child, that you think maybe it's not classical autism, but you could send them to us?
I'm really loath to answer that because we are absolutely flooded with referrals. We have something like a 2-year waiting list. So I'm loath to encourage even more referrals. I think realistically, keep to what you're doing at the moment. But I think with time, when we're getting better, both you and I, when we're getting better at diagnosing, then I think we would have got rid of not got rid, but would have diagnosed the obvious people, and then we can get more to the subtle people. But yeah, I think the AQ50 is a good way to go though, or the AQ10.
Okay, so we have there's no other questions at the moment. There's one other question, but we have a lot of adults who we see who think might have ADHD. We have parents with children that they think might have ADHD. If there's a 2-year waiting list, before I ask about referral pathways, if there's a 2-year waiting list, what can we do for those patients, or where can we signpost them to get support during that 2 years?
I'm assuming you mean autism, not ADHD. You kept saying ADHD.
Sorry, autism. Sorry.
Very hard to answer that. The autism service is a diagnostic service, so we do. Yeah, there's no sort of way to get around that. We are as a service, we are desperately trying to catch up. We have been given some extra money by commissioners to try and catch up, because I think commissioners are recognising the scale of the problem. It's not just LPFT, not doing a good job. It's just that there are so many people with autism out there. At the moment, we try to see people with autism who had a clear health need. So if they've got associated mental health problems, if they're clearly very, very anxious. So that's how we try to see the more important ones first, the more urgent ones first. But there is no good answer to that question, Runa. It is what it is. I don't know how else to answer except to say that we are trying to catch up.
Okay, thanks, Peter. So the next question is from Angela again. And what proportion of patients with autism have ADHD symptoms, and is there a clear link?
First answer, I don't know, but there is definitely a clear link. Yeah, autism and ADHD well known to occur comorbidly. They're both neurodevelopmental disorders, definitely linked, but I don't know the actual rate. I couldn't even guess on that. I just know that they are linked, definitely.
Okay, thank you. What support is available for those with autism locally in terms of support groups? Do you know?
Okay, there's two answers to that. What I should have said, not only do we have an autism diagnostic service, we also have an autistic liaison service. So it's post-diagnosis. So you can't refer straight to autism liaison, I'm afraid. They have to go through autism diagnosis. But then we do have a small team who help people with autism. And it's really helping them cope with things like getting employment, also just coping with social situations. They offer a set number of sessions. I don't know how many. I'm going to guess, say 5 or 6 sessions. Again, they're flooded, but yeah, they do offer some support. Beyond that, let me see if I can find my resources. I have got some autism. Where are we? There is, I haven't got it because my computer died on me a few months ago, but I know that there is an autism support group in the south of the county. Bear in mind though, this was pre-COVID, so I suspect they've gone online. But the best thing to do is just go on Facebook and you will very quickly find autism support groups. So there's definitely one in the south of the county. There also used to be a specific horse riding stables for people with autism. I sadly, I don't know the name of it, but again, I would go on Facebook and if you just put in autism, I think you'll very quickly find these things. The problem you've got, some people with autism don't want to know, they don't want to meet other people with autism. They're very insular, they're isolated, but they're happy the way they are. Whereas other people definitely do want to meet other people with autism. So it purely depends on the individual. But then, of course, you've got the carers, the families, and they might be wanting support as well. So again, there are support groups. Again, go on Facebook.
Thanks, Peter. I wonder if Henk wants to unmute and ask questions. He's put a couple of comments in there.
I'm just going to adjust my curtains again.
Okay. Is Henk there?
Yeah, can you hear me?
Yeah, we can hear you. Just give Peter a second whilst he comes back from sorting his curtains out. Thank you.
Oh, we're all right now. The sun's moved.
Brilliant. Peter, we've got Henk on the call asking a question.
Hi, you answered the first question. There is obviously clear association between autism and ADHD. What I find with referrals that you've got to make up your mind as a GP. There is a separate service for autism as for ADHD. And I see particularly in my practice an awful lot of people with a combination of it. It's not either or, it's usually and. And that creates a real referral problem. And sometimes it is that obvious that you're almost tempting to say, well, you get a lot of pressure to put in some people to put on medication. And I think a lot of them have actually unrealistic expectations what that medication does. It's not going to change the person. A lot of them, they just got certain incapabilities, and you need to work around it. You can't actually change that. Have you got any views on all of that?
Well, the first one is that it's bad news, because LPFT, we're not. It sounds a horrible excuse. I'll just have to say it. We are not commissioned for ADHD. What happened was a couple of years ago, Dr. Jar, one of our psychiatrists, was running a clinic specifically for adults with ADHD. And we were hoping that commissioners would then extend that clinic county-wide. It never happened. So that's the bad news. I was just thinking, though, while you're talking, for me, if I were to sort of refer one way or the other, I would be thinking ADHD first, because the ADHD you can treat with psychostimulants, and some people do respond very well to those, whereas you can't treat autism. You know, autism is just the way somebody is. Somebody with autism wouldn't say they have a problem. They would say, actually, we have the problem. Like I said earlier, we're the ones who lie, cheat. You know, we deceive people. People with autism generally don't do that. So they would say, we have the problems. So, yeah, I think I'd be referring for the ADHD. But again, the problem is there isn't a service. There is the Autism 360, which I know very little about. I think it's run by Natasha Gopi, who used to be one of our psychiatrists. But yeah, if you look at Autism 360, they may be able to help you. But it's far from ideal. And while you were talking, Henk, I was just thinking, actually, we should have a combined service. But that's not been thought of yet.
I think so too, because there's so much overlap. And the other kind of thing I wanted to bring up, I started to get interested in autism for various reasons. But one of them is that in the Drug and Substance Misuse Service, there came this article from Professor Ginsberg from Stockholm in Sweden, who sort of said all these prisoners, they've got a lot of them have got ADHD, sift them out, stabilized on methylphenidate, and the reoffending rates diminished. And that was hugely interesting, because then I thought, you know, in the prison population, drug and substance abuse, and I've worked there for in about 10 years, you might actually do a bit more than just sticking them on methadone. Some of them are so badly managed, that might actually well improve their symptoms. Is that something you connect with, or is that something which is more like a different service?
I don't know if this is answering your query, but I'm just thinking about David Nutt. I don't know if you know David. He was the man who said that cocaine was safer than horse riding, and he got castigated for it. But anyway, I went to a talk from him, and he always said that for people with substance misuse and ADHD, if you give them psychostimulants, as a general rule, the substance misuse improves because they gain more control, their impulsiveness improves, so they tend to substance misuse less. So rather than having the fear of giving them a drug of abuse, i.e. a psychostimulant, you actually make them better, not worse. Is that the point you were making, or are you making a different point?
Yes, no, that's absolutely exactly the point I'm making. Because the prison population gets somewhat nervous about this because they all think it's highly addictive and it's just like coke. But in actual fact, no, it isn't. It actually, in fact, does help to stabilize them, because half the reason that they live in this distorted world is to resort to drugs in order to sort of stabilize their mind in one way or another. It's obviously very complex and it's not one-dimensional, but stabilizing them. And some people have managed to stabilize in the prison service. They are far better on those drugs than they are not, but it's not universally accepted, I'm afraid.
Yeah. And I mean, if somebody with ADHD is going to respond to psychostimulants, they respond almost instantly. It's one of the best drugs you can give. They almost improve in front of your eyes. So yeah, I can only completely agree with you, Henk.
So then the next point is all the drugs are now licensed for only as shared care. Do you think in time we will move towards almost like GP or GPSWI initiation? Or do you firmly believe it can be so dangerous to try it in people who are neurotypical that we should stay off that?
I got a bit lost with there. What's WI?
GPSWI is GPs with special interest.
Oh, right. Yeah.
So the question is, there is clearly a gap in service delivery. That's not your fault. It's nobody's fault. I think part of it is that it's recognized so much more. Social media, internet, people recognize from much earlier stage, before they have actually seen a GP, that they've got ADHD or they've got autistic features. So this is a floodgate going to open, and some people will benefit, some people will not. But ultimately, we can't prescribe anything because it's a shared care drug. So we have to have an endorsement of a psychiatrist in order to initiate that. I know there have been other people who kind of, in the Royal College of GPs, who suggested perhaps we should not make it a shared care drug, but the GP could initiate that, similar to like an antidepressant. Don't know what your views are on that, and I'm sitting on the fence on it. I'm not sure which way that needs to go.
I would love GPs to be able to prescribe psychostimulants. They're actually surprisingly straightforward. Like I said, you see a response almost instantly. I'm never quite sure if they're addictive. I was always taught that they're not addictive, though you can get psychological dependence. I think the stumbling block is that they're controlled drugs, and I think that's where everyone gets twitchy. But for me, I mean, I'm basically self-taught at giving ADHD drugs, and it's not difficult. It really isn't. So I would say GPs prescribe, but I'm sure other people would completely disagree with that view. The other thing I was thinking while you were talking, I've been a bit disingenuous towards LPFT, because we do have a new transforming care service, and this is for people with mild LD, and it's for people with autism, and it's helping people with autism access generic services, and it is within LPFT. So basically, if we've got somebody with autism referred with depression, the transforming care team might help that individual go and see the general psychiatrist. So they're not going to directly help you as GPs, but they are going to help the experience of the person with autism, because we've realized that we're really failing people with autism. So things are beginning to change, but not so much for the ADHD, I'm afraid.
Okay.
Thanks, Peter.
I could talk until midnight, so let other people.
Well, there's just one other question in there, actually, Hank. So I'll ask that for you from Dan. Dan says he's had a few autistic patients presenting with gender dysphoria. Is there a link? And how would you advise we help these people? Should we manage them any differently to others presenting with gender issues?
Oh gosh, you've opened a whole can of worms there. I mean, I'm fascinated the sort of national debate about transgender, well, LGBTQ plus. I think it's just such a huge issue at the moment. I'm going to talk a bit widely now. You know, should you have gender specific toilets? Should you allow a transgender a transgender female to compete with other females, you know, in sport? Such a huge issue. You are asking, are they related? Is gender dysphoria associated with autism? I don't know the definitive answer, but I suspect it is. In fact, I'm pretty sure it is. I think any young adult can struggle with sexuality and sexual identity, and I think it's just 10, if not 100 times worse for somebody with autism. So I'm pretty certain they are related. What was the other part of your question?
Should we manage them any differently to others presenting with gender issues?
I don't think services are sufficiently advanced to answer that. I think this is all going to be in the future. I think that perhaps we will develop more services like that, but I don't think they're here yet. So I think at the moment, I would argue you treat them the same, but this is such a fast evolving field. I think I could be out of date in a year. So I think watch this space on that one.
Thanks, Peter. And Dan saying thanks as well. Ewan's kindly said that she's heard there's a autistic children's support group in Lincoln called PACT, and she's going to attach the links if needed. I expect we'd find it on Google or Facebook as well. That's a useful way to look for it as well. But thanks, Ewan. There's no other questions in the chat at the moment. Is there anyone else who had anything else for Peter?
I was just thinking whether I got any nice anecdotes I can tell you, because I can talk about autism for hours, but of course now I'm on stage, I can't think of anything.
There is one thing. Can I just say one thing? There is about gender dysphoria. I can't remember the YouTube website, but there is a lady who talks about autism, who's got autism herself, and so have her children. And what they say is that these relationships in autistic people are defined by what they can do in common rather than what they feel have in common. So you often find that gender is not so important. It is more what activities you can do together, and that will explain where you see a lot of bisexual and transgender features or relationships in the autistic population as a result of the fact that they don't actually sexually relate to each other, but they relate in terms of activities to each other.
That makes complete sense. However, I would challenge that a bit, because I would argue the idea that people with autism can't sort of develop emotionally entwined relationships is a bit out of date. But I do get the point that they're making too. But I think people with autism can develop relationships. I think it's just harder. But you're right, it might be that they're looking more of activities rather than sort of more emotional feelings. But I've known people with autism, they have all these emotional feelings, they just can't express them. Perhaps they can't even recognize them, but just expressing them is so difficult. I was just thinking, to give you some anecdotes, there's a very famous woman with autism in America called Temple Grandin, and she's written extensively about autism. And she talks about having a great affinity for cattle. She doesn't understand us human beings. She says we're far too complex, but she understands cattle. And what she's done, she's designed these cattle ranches in the US for cattle, and one was at the abattoir. And what they used to do, they used to have a huge ramp going up, and at the top a bolt would come racing down, hit the cow on the head, stun it, and it would fall over into sort of the pit below. Not surprisingly, the cows at the bottom could see what was happening to their mates at the top. They didn't want to go up the ramp. And Temple Grandin just very simply designed a helical ramp rather than a straight ramp. So the cows at the bottom couldn't see the cows at the top. So they just happily walked up the ramp. So, yeah, it takes somebody with autism to see something as simple as that. Another thing she talked about.
Sorry, Peter, maybe she should go into politics.
Another thing she talked about, do you remember earlier I said some people with autism, you need to hug them really tightly? What she found was that cattle, when they were placed, basically to inoculate cattle, they're put into this sort of cage, and then people pull these huge levers down to really clamp the cattle in place, hold them still. And she observed that the cattle paradoxically became much calmer when they were really tightly encased. So she actually designed this for herself. It was bizarre, but she sort of walks into this cage and then she pulls these levers down, and she said it was intensely relaxing. And what we do find, you may have heard of weighted blankets. Some people with autism will respond to weighted blankets, and these are heavy, you know, they're very, very heavy. But it's the idea that the light pressure people can't cope with, but the really firm, hard pressure people can cope with. So sensory issues are so important in people with autism, and it's trying to work out what the sensory thresholds are, what the sensory differences are. Oh, I could talk for hours, but I'll shut up.
Can I just ask one last question then? Is it worth in filtering to the CCG that perhaps the shared care initiation of methylphenidate is something which may need loosening up in order to provide a more timely service delivery? What are your views on that?
I'm sorry, Henk, I only got half of that. You were talking about shared care. Just give me the basics again.
I think, Peter, it's about sorry, Peter, I think Henk was talking about the what your views were on the shared care of methylphenidate and working with the CCG to sort of maybe speed up those pathways.
Well, I've told you my view that I think GPs should be allowed to prescribe, but I'm aware this is very political, so I'm not going to commit myself any further, I'm afraid. But I think at the ground level we could sort this out, but of course it's all political, so we have to leave it up to the higher beings to decide the way forward. I'm sorry, I can't really answer more than that.
Okay.
And of course, Peter, then GPs, it'd be another role for us to take on and having time for us, but it would certainly take time away for that. It'd be better for our patients if they didn't have such longer waits. Thank you. So I think we're done with questions for now. It's been a really interesting talk. I picked up some really good tips, even the simple things like the fluorescent light in the room and checking with patients that they're okay with it, and actually for us not to look at the patient when we're a patient with autism when we're talking to them and how it might be more comfortable for them.
They won't be offended. They won't be offended at all.
Absolutely, and I think little tips like that for me have been really useful, as well as the whole talk in general, and it's generated some debate as well. So we really appreciate it. I will make sure that we share the video more widely, and if there are any questions related to autism, then we'll try and send them your way. Hopefully there won't be too many, because obviously you've got long waiting lists. But if it helps us help our patients and reduce your waiting list, then it might be beneficial. So thank you very much for your time and for your interest.
And thank you everyone for your attention.
It's brilliant. And we've had some thanks already in the chat. Thanks very much, Peter. I'll stop recording now. Have a nice evening, everyone.
Bye everyone. Thank you.